So let's see what we had in the optometric trends.
So this was in March. So
yeah, this was in March.
Before we had any opportunity to treat.
Yeah, and this was...
What are your 2 top treatment recommendations for a patient with Demodex? So what was number 1 there? Lid scrubs, which I personally feel, Doug, is we should not abandon lid scrubs.
Oh, I agree. I totally agree.
I mean, I think, again, the key word is we're managing this. Because the one thing that I think neither one of us have mentioned is I tell patients that we can't eradicate them forever. What we can do is bring them to a level where they're not going to be causing symptoms, hopefully, and then we need to reassess it. And much like cleaning teeth.
No, and I think that the treatments that we had and that, we were just kind of superficially doing things, and we may have been knocking some collarettes off.
Right.
But, it's kind of like the chips, eat all you want, we'll make more, because they will.
Yeah, I like that.
Yeah. So some of the common treatments were tea tree oil, the lid wipes containing tea tree oil, topical ivermectin cream, cleansers and hypochlorous acid, lid scrubs, antibiotics. And it's interesting, the cleansers and hypochlorous acid, I mean, they really found out didn't touch mites.
Right.
That they, that you could put a mite underneath a slide, which they did, fill it full of hypochlorous acid. One of our friends, Al Cabot, did that.
Yep.
And the mite just kept on swimming around for 24 hours. We were just having a good old time.
Yep.
In office now, you can use intense pulse light where you're indirectly affecting microblepharoexfoliation where you're taking away the food source, taking away the biofilm, and reducing some of the collarettes as well with that, because that will actually, the microblepharoexfoliation will take away those collarettes, but it doesn't necessarily take away the mites.
Right, and I think that's the key here, is that the superficial aspect of it is that we can kind of control that, but if you still got the mite party going on there, then you got to slow down that rager. You know, you got to slow down that rager.
Yeah, got to slow it down. So, and in this tea tree oil and lid wipes manage the collarettes, but aren't treating the root cause again.
Yeah.
Same thing we just talked about.
So let me ask you a question. So if you have somebody who's like, let's say on oust, right? From our friends over at OcuSoft, would you have them stop using that, or would you have them still continue it?
Well, I'd still have them continue it, and I think we will see in the studies where lotilaner was looked at is they couldn't touch their lids, really. They were just putting drop in, they weren't doing that, and yet they were looking for the reduction of collarettes. And some of those collarettes are going to hang around for a while. Like you said, the lash needs to grow out. So what I have the patient do is, during the treatment, is I'll also have them do lid scrubs.
Yeah. And for me, what I'm also doing is that, we see here that this is, the first, treatment. And I'm going to do a little shout out to Laura Perryman, lotilaner. Cheers, my friend, lotilaner. This is not new to medicine. I mean, veterinarians, we get so much from veterinarians. Think about cyclosporin. Where did that come from? Uga. Right, from vets. When we look at lotilaner, this comes from veterinarians. Same thing, I think, for ticks and flea treatment. It paralyzes and it eradicates them. But to the point you just made is that this is a process. It doesn't go in, boom, they're all dead. There's still eggs that are still inside there that has to basically be paralyzed. So using the lid scrubs and still managing superficially, here's my other thought on that, Doug. And this isn't breaking news, but it could have been, is that our patients are not compliant. Breaking news, your patients are not compliant. Come back to us at 12. They're not. So if we can say, here is a drop that we're gonna use for 6 weeks, twice a day, but also at least once a week or every other day, or then you know that at least it's gonna trickle. We're gonna get that. So yeah, we gotta make that happen.
And I love this graphic because it actually shows this like a little electrical thing going, and it's paralyzing the mite is what it does.
That lipophilic molecule gets in there.
Yeah.
I have had no patients have really any side effects associated using this medication.
Yeah, neither have I.
Yeah.
So far it's been very successful. We've had this, and we'll continue. We'll kind of show some of the other studies and look at this SATURN-1 and SATURN-2. Big studies, 833 patients, and they were randomized to have either lotilaner or the vehicle and dosed twice daily. Colorette reduction. So less than 2 collarettes. And it's interesting that this was one of the endpoints that the FDA set up, because that's not the mite. The collarette is what is left behind by the mite. And if you can't rub, then you can say, actually, there could be some collarettes left over after this.
So the primary endpoint was to show a reduction of collarettes less than 2. So there's 150 lashes, and basically saying you have about 2 collarettes, so 2 lashes that have this. The average in the clinical trial was a grade 3, which is to the left there, which is about an average of 100 collarettes. And that just blows me away, because I would probably not even see the collarettes one that's less than 2. So it's almost like you don't have to look at somebody where it's 0. It's just that manageable aspect, you know?
And that alone was 50% when you get down to that.
So 50% of the patients had like a grade 2, 3, and they're 3, 4, and now they're basically down to between a grade 0 and a grade 1. Beautiful, beautiful. This was such a clean study. To do a clinical study, you have to have 2 arms showing identical, you know, same exact primary endpoints and secondary endpoints. And you have to meet them in both of those studies. And oftentimes, a lot of studies, it's challenging for them to meet them in both of the studies, or signs may be in one and symptoms aren't in the other. This was a robust, clean study, and they did a really, really phenomenal job.
And it repeated itself very, very well.
Yeah, I mean, look at day 43, what, 55%, and then what, 44% in the other study. Pretty exciting stuff.
And that doesn't mean that it works in 50% of the patients. That means that it is so overwhelmingly
that's 50% of the patients were down to that, like almost 2. I mean, look at this. Look at the menage a trois happening on the lash right there. And then, boom, lotilaner comes in and says, you know what? Your mite party is canceled.
It's done.
This is cancel culture at its best, Doug. Do you not agree?
I totally agree.
Okay, thank you.
What's interesting, when they actually epilated these lashes during the study, that the average over all the lashes was like 2.5 mites that were. And so when I see collarettes, it's not because a mite create that. There's not a mite that's doing that. There are mites that are overpopulating, and that's why even if I see small amount of collarettes, I know that's something that I want to take care of.
Yeah, 100%. And in this study, look, they found 60% of the patients, when they pulled the epilated the lash, then they put it under the microscope. But you see in the study here, when they pulled them 0 lashes, 68% and 50% had no mites at all. And as you said before, the average was like 2.5. So the other 30 or 40% maybe had 1, you know, it was very limited. So what else did they study?
And then, you know, I don't know if you've talked to Laura Perriman, one of our colleagues.
LP, lotilaner.
And we were doing a program together, and she said, she was part of the study. She goes, my record was 15 mites on a lash.
Wow.
Here's another aspect that in taking care of erythema, those patients, when you start getting into a level 3, level 2, level 3, their eyelids, just like the video that you showed of your patient, those were red, thickened, irritated eyelids. So
telangiectasia, neovascularization towards the end there. You know, the funny thing about this is that I almost kind of feel like it's innate that you're going to have a reduction in erythema, but there's so many other things. There's this in this multifactorial world that we live in, that the fact that we can reduce it at all is a Benny. The fact that it doesn't go to 0 is because it's impossible. You saw the contact lens users, the cataract users, the patients that already have pre-existing dry eye.
And collarette reduction, I think this is the most impressive number. Collarette reduction to less than 10 when it started out at what, 150?
Yeah.
And less than 10, 85%. And honestly, Mark, this is what I've been seeing so far in my clinic.
So have I.
You know, and one of the important aspects when you look at this is this right here will say at day 15. So I had a number of patients that I had on a list, so I prescribed this, and then they just happened to be coming back in 2 weeks, in 3 weeks for their regular scheduled appointment, just because I'd sent them in. And these numbers really duplicated that at Week 2, you're seeing an improvement.
Yeah.
You're seeing a dramatic reduction in the collarettes by that time. And then as it goes through the course, even greater.
Well, I mean, even at the very least, Doug, that picture that you showed a few seconds ago, if you go back, even if you don't subscribe to the fact that your patients are symptomatic, and I love how you say you have to say might, because when somebody asked me, what is it that I'm excited about with the lotilaner? Well, I'm excited that it might make my patient's vision sharper.
Yeah,
it might
might.
make them not itch. It might make them less cranky. And, you know, so to me, it's like you saying the word might, it's hope. I mean, I look at that picture on the left and it's like, I don't care what possibly is I guess, what the symptomatology is, it can't be good. And the fact that I can now make it look to the right and make it look cleaner, less than 2, why would we not do that for our patients?
Yeah, well, exactly. And I think a lot of times that becomes baseline for patients.
Right.
If they're just living with
Sure.
it.
Yes.
And how many times have you heard family members or people you know say, you know, they had a little bit of malaise, they weren't feeling good, but they didn't realize how bad they were feeling until they
Right.
felt good again.
100%.
And that's what I'm seeing now with the results as the patients are going, you know what, my eyelids feel good. Yeah. You know, we've talked about this before, Mark, that, you know, you shouldn't ever be aware of your eyes, just like your teeth. If there's
Right.
something going on with if you're aware of your teeth, there's something going on.
But you know, you bring up another point too, is that I've had patients say, do your eyes ever itch? And like, no. And then they're like, well, now that you say that, and then I've had patients come back and say, I feel like I'm not reaching for my eyes as much as I did before.
Yeah. And it's interesting when you ask patients, do you ever feel like you need to itch your eyelash?
Right.
A lot of patients will say, well, not really. And then they stop for a minute and they go, you know, maybe I do. And 2 weeks ago, I had a patient and I asked her that, and she was about a level 2 collarette. And I said, do you ever find the need to scratch or itch your eyelashes? And both the tech and I thought that she was just like being sarcastic.
Yeah.
She reached up and she pulls on an eye and then she says, no, and she reaches for this. She goes, no, I don't think I ever do.
Yeah.
And I said, no further questions. You may step down.
Yeah. This slide too is another beautiful thing, is that this is a very comfortable job. Very little to no adverse events reported with the exception of a little bit of stinging, a little bit of blurred vision. And you want to prescribe something that you can tell patients, look, I'm gonna help you eradicate this without causing secondary, you know, like dysgeusia or eye pain or burning or stinging. And I think that's really important to patients. And I don't know why, but I almost kind of feel like that goes to the root of the drop being beneficial.
Yeah, I agree. This tolerability, and also this is a very motivated patient, and that's why you have to use the word might.
It's funny though, is that remember we go back to compliance, and I've always subscribed to the belief that patients will come up with an excuse because they don't want to do it.
Right.
Oh, you know what? It smelled. Or I had a patient tell me that the other day. And I go, really? I go, no, nobody's ever told me that. I go, maybe it's right here. You got something right there. And he goes, you think? I go, I don't know. I've had some patients say, you know, things like, oh, you know what? I couldn't get it. And I'm like, well, let me help you get it. You know, it's just, I feel like there's barriers that people put up.
Well, you know, we have something special right now.
Oh, do we?
Yeah, we do. We actually have an interview with a mite.
We do not.
Yes, we do. We have an interview with a mite. Mr. Mite. Can I call you Mr. Mite? I'm not really sure. What's your name?
People like to call me Wendell. I am Wendell. Hello. Hey, everybody out there. It's me, Wendell, the mite. You might think I'm super sexy, but you might not.
Well, Wendell, it doesn't sound like you're from around here.
Oh, au contraire, my friend. I am from everywhere. All the time, all the place. Like right now, I am from France. But who knows? Maybe I'll be from Russia. You'll never know who I am. I'm everywhere.
Well, Wendell, you have to be a little concerned because it seems like there's a lot of U.S. doctors that are after you these days.
Yes, it's a little scary right now being the mite because I don't know why. I look at me. I'm sexy. I'm cute. I look like baby seal. Why? Why do you want to kill? Why do you want to kill? CILL, why you kill me?
Well,
I love yous. I love all yous. I have party in your follicles. I love yous. Do you want to take a toke? Come, party with me.
Well, Wendell, I understand that you're part and have initiated a class action suit and bringing PETA into this because they're trying to go after you.
Thank you for bringing that to attention, Didi. We, in the ectoparasite community, we are very concerned about the fact that people want to kill us, okay? We called, what's her name, Sarah, whatever, the singer. We went commercial, late night, you know, with the dogs and the cats, and we just feel this is not right. So, as a organism that is partying, a party organism in your follicles, just maybe be more kind. Be more. Look at me. Would you kill baby seal like me? No, I'm a baby seal.
Well, Wendell, you're very congenial, but I got to be honest with you. I want you dead also.
I want you dead, dog.
Well, I kid. Well, you know what, Doug? Don't worry. Lots of my friends are all over your lashes because when you're over 70, we are there. All right? We're there. So.
And thank you, Wendell. We appreciate you coming
Good.
into the
Hey,
set
no
today.
more might. No more killing me.
We
okay?
appreciate you coming in.
I
Thank
love
you very
you.
much. And we're going to move on with our program now.